Extract 1, questions 1 to 12. You hear a pulmonologist talking to a patient called Robert Miller. For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Good morning, Mr. Miller. Now, looking at your notes, I see you've been having a few problems recently. Could you tell me a little about what's been happening in your own words?
Well, yeah, it's a combination of things, really. To kick off, I feel pretty tired most of the time. Just haven't got the energy I used to have.
Right.
And I've got this cough. It's there all the time, and it feels dry. I mean, I'm not coughing up phlegm or blood or anything like that. But the worst thing, which really bothers me, is that I'm so short of breath. Even if I'm just getting dressed in the morning or going up a few steps, I have to stop because I get breathless so quickly. And I've lost quite a bit of weight, too. I mean, I didn't notice at first because it was very gradual, but all in all, I'm about 10 kilos lighter than I was 6 months ago.
Right.
I've not been dieting or anything. I love my food.
Okay. And, well, have you noticed anything else?
Yeah, just take a look at my fingers. The tips look swollen, don't they? And it's the same with my toes, which are bulging out at the end, too. It's weird. And my nails, I don't understand it. They've become soft. They're not hard like they used to be. Look.
Okay. I see what you mean. And tell me a little about yourself. What you do for a living.
Well, till recently, I worked as a farm laborer. Did it for about 20 years in total. It was hard, physical graft, and it finally got to the stage where I just couldn't cope with it anymore.
Right.
It really took it out of me. So this last couple of years, I've been a security guard, working nights at a local DIY warehouse. It's a bit boring, and the late shifts took a bit of getting used to, but it's okay.
And, are you finding it less physically demanding?
That's right. I just haven't got the stamina now for anything else. In fact, I've even had to give up my golf. Can't manage it anymore. Any spare time now goes on looking after my pigeons. I've done that since I was a teenager.
Oh, very nice. And what about your medical history? Now, I see you were diagnosed with hypertension last year, and you're taking beta blockers at the moment for that.
That's right. My GP said it'd help. Something the GP also said when I saw him about my breathing problems was that he heard what he called crackling noises in my chest.
Okay.
I can't hear them, but he could, through the stethoscope.
Okay. And is there any family history of breathing or lung problems or any serious illnesses that you know of?
I don't think so. My mother was always healthy, but my dad developed bad eczema as an adult. I remember the red patches on his hands and face, but he didn't have any lung problems as far as I know.
Right. And, well, looking at your previous tests, you were diagnosed with hypertension about 6 months ago. You had...
Oh, yeah, an echocardiogram, to check my heart.
Yes.
And a chest x-ray about 4 weeks ago after I saw my GP. That came back okay, as far as I know.
I see.
I'm not keen on hospitals, to be honest. Am I going to need to have lots more tests?
Well, I'm going to suggest you have what's called an arterial blood gas test. This will let us check how well your lungs are working, how they move oxygen into your blood and remove carbon dioxide from it.
Okay.
And I'm also going to order a CT scan. Now, this will be more revealing than the chest x-ray you had, and I may then prescribe a course of corticosteroids. This will depend on what the tests show up. Now, I'd start you on a relatively low dose, and then we'll see how...
Extract 2 questions 13 to 24.
You will hear part of a consultation between a doctor and a patient called Mrs. Chambers.
For questions 13 to 24, complete the notes with word or a short phrase.
Hello, Mrs. Chambers. I'm Dr. Bakari, one of the obstetricians working here at the hospital. I've just come to ask you a few questions. What is the reason you came into hospital today?
Oh, well, I started bleeding.
Oh, I see. When did you start bleeding?
I had a bleed on last Sunday.
Okay, and how many weeks pregnant are you at the moment?
I'm 36 today, and I started bleeding about a week ago.
And did you have any bleeding before that?
Actually, yeah, I did, in February.
Okay, in February. How much bleeding did you have? Was it quite a bit or just spotting?
About half a cup full, and I was 28 weeks then. But, the bleeding only lasted for not long, a couple of hours, then it stopped.
Okay, and when it started last Sunday, how long did it last then?
It lasted for about 3 hours, but then I'm spotting and having some old blood coming out now. Yeah, and it was quite a bit of blood. I would say about a cupful.
A cup, okay. And with this episode, did you have any pain anywhere at all?
I just get a tightness in my tummy and I get cramps. And a quite severe pain in the lower abdomen, here, for a bit. But it comes and goes. It started when the bleeding, at the same time as I was bleeding.
Okay, and did you have pain at 28 weeks when you had the bleeding then as well?
Yeah, it's just like period pains, cramping.
Okay, all right. Any other symptoms at all?
No, not really.
Okay, and with this pregnancy, other than the bleeding, have you had any other problems?
No.
Okay, and have you had a scan since this bleeding started?
Yes, I had one when I was 34 weeks, and they found the placenta was low, but I haven't had another one since.
Okay, and when is your next scan due?
I haven't got another one now.
Okay, all right, and when you had your booking scan at 12 weeks, everything was normal then?
Well, in my first scan, they struggled at 12 weeks to find it, so that was sort of like an internal scan, but they just said it was because it was a small baby or something. But other than that, everything was normal, I think. My visit at the antenatal clinic, everything was normal. I remember my Downs risk was low.
Okay, so everything was fine. That's good to hear. All right, have you had any previous pregnancies?
Yeah, I've got 2 little boys. They're 2 now. Both very healthy, just a bit naughty.
All right, they twins?
Oh, yes, sorry, they're twins.
And was it a normal delivery or was it by cesarean section?
No, normal.
Normal delivery, no instruments used, nothing like that? And you didn't have to go into the intensive care unit or neonatal unit, nothing like that?
No.
Okay, all right. I think I'm starting to get a good picture. Tell me, have you ever had any uterine surgery or procedures?
Oh, yes, about 4 years ago, I had to have an abdominal myomectomy.
Oh, I see. That's good to know. What symptoms did you have with that?
It was almost exactly 2 years before my boys were born. I was really suffering, migraines, body aches, and even a fever with my period. One time the pain got so bad I had to go in for an MRI, and they found some pretty big fibroids, and at the time we were struggling to get pregnant, so the doctor suggested I have the fibroids removed. I was really nervous and considered not getting it done, but it seemed to work really well. And 2 years later, we had our boys. I never really felt any ill effects from the procedure, apart from just taking time to heal.
This is the end of Part A. Now look at Part B. Part B. In this part of the test, you will hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare environment. For examples 25 to 30, choose the best answer, A, B, or C, which fits best according to what you hear. For you will have time to read each question before you listen to the audio. Complete the answers as you listen to the audio. Now look at question 25. You hear a discussion between 2 doctors about the complications which are expected at a later stage following heart attack.
Hello, doctor. What types of complications are expected at a later stage following a heart attack?
Well, there are certain complications that arise at a later stage following heart attack. In the condition called aneurysm, a scar tissue builds up on the damaged heart wall, resulting in blood clots, low blood pressure, and abnormal heart rhythms. In the condition called pericarditis, the lining of the heart becomes inflamed, causing serious chest pain. Angina occurs when there is not adequate oxygen to reach to the heart, causing chest pain. During congestive heart failure, the heart beats very weakly, leaving a person feeling exhausted and breathless. In the condition called edema, fluid accumulates in the legs and ankles, causing them to swell. Loss of erectile function is caused by a vascular problem. Loss of libido or loss of sexual drive happens, especially in the case of men. Question 26. You hear a discussion between a doctor and a nurse about uterine fibroids.
Hello, doctor. What are uterine fibroids?
Well, uterine fibroids are benign tumors that may grow in various parts of the uterus of a woman. Intramural fibroids are the most common type of fibroid that appear within the muscular wall of the uterus. Intramural fibroids can grow larger and stretch the womb. Subserosal fibroids form on the outside of the uterus called the serosa, and may grow large enough to make the womb appear bigger on one side. Submucosal fibroids bulge into the uterine cavity. Pedunculated fibroids are attached to the uterine wall by a stalk-like growth called a peduncle, which is the main difference between pedunculated fibroids and other fibroids. If a pedunculated fibroid forms in the middle muscle layer or myometrium of the uterus, then it is called pedunculated submucosal fibroid, and if it forms outside the uterus, it is called a pedunculated subserosal fibroid. Question 27. You hear a discussion between a doctor and a nurse about acquired digital fibrokeratoma.
Hello, doctor. What is acquired digital fibrokeratoma?
Well, an acquired digital fibrokeratoma is a benign tumor usually occurring on the fingers and toes, which is an uncommon condition often seen in middle-aged people. Usually the tumors have a dome-shaped appearance, but can also look like elongated projections in some cases. Acquired digital fibrokeratoma lesions are usually isolated, but are also associated with other tumors, in very rare cases. A type 1 acquired digital fibrokeratoma lesion is dome-shaped and has a dermal core that is made up of a thick, intertwined bundles of collagen, which are typically oriented along the lesion's vertical axis. There are numerous capillaries, thin elastic fibers, and fibroblasts between the bundles of collagen. The type 2 acquired digital fibrokeratoma lesions are less common, Although they appear similar to type 1 tumors, histologically, they are typically tall and also have a considerably higher number of fibroblasts and fewer elastic fibers. A type 3 acquired digital fibrokeratoma is very rare, and the tumors are fluid-filled and have fewer elastic fibers. The lesions can be flat to dome-shaped. Question 28. You hear a discussion between a doctor and a nurse about pelvic organ prolapse.
Doctor, what is pelvic organ prolapse?
Well, pelvic organ prolapse refers to the condition in which one or more of the pelvic organs suffers descent from their normal position in the pelvis. It may be congenital, or acquired defect, or weakness in the normal pelvic supporting structures. The anatomical categorization describes which organ is primarily involved in the descent. Urethral involves the anterior vaginal wall, and urethra descend into the vaginal opening. Cystocele involves descent of the anterior vaginal wall and bladder. Cystourethral involves the prolapse of the bladder and urethra along the anterior vaginal wall. Uterovaginal prolapse involves the descent of the uterus, the cervix, and the vaginal vault. Enterocele prolapse of the posterior uppermost part of the vagina with loops of small intestine that have accumulated inside. Rectocele involves descent of the lower posterior wall of the vagina and the rectum which bulges into it. Question 29. You hear a discussion about hematuria.
Hello, doctor. What is hematuria?
Well, hematuria is a health condition that is identified by the presence of blood in the urine. Microscopic and macroscopic are the two major classifications of hematuria. The different types of hematuria categorized based on the cause are: infective hematuria is caused due to pyelonephritis, cystitis, or urethritis. Stones-related hematuria is caused due to staghorn calculi, calcium stones, or uric acid stones. Trauma-related hematuria is caused due to pelvic trauma, renal injuries, or foreign bodies. Renal hematuria is caused due to immunoglobulin A nephropathy, hereditary nephritis, medullary sponge kidney, or thin basement membrane diseases. Latrogenic hematuria is caused due to recent endoscopic procedure, transrectal ultrasound, traumatic catheterization, radiation, indwelling ureteric stents, renal biopsy, extracorporeal shockwave lithotripsy. Benign hematuria is caused due to strictures, renal masses, or benign prostatic hypertrophy. Malignant hematuria is caused due to prostate acinar adenocarcinoma, or renal cell, transitional cell, squamous cell, or urothelial cell carcinoma. Question 30. You hear a discussion about types of collagen and associated disorders.
Doctor, can you explain different types of collagen and associated disorders?
Well, there are about 29 genetically distinct collagens present in animal tissues. Collagen types 1, 2, 3, 5, and 11 self-assemble into D-periodic cross-striated fibrils. Here, the D is about 67 nanometers, and there is characteristic axial periodicity of collagen. Type 1 collagen is found throughout the body except in cartilaginous tissues. It is the main component of bone. It is also synthesized in response to injury and in fibrous nodules and fibrous diseases. Type 2 collagen is the main component of cartilage. It is also found in developing cornea and vitreous humor. These are formed from 2 or more collagens or copolymers rather than a single type of collagen. Type 3 collagen is found in the walls of arteries and other hollow organs and usually occurs in the same fibril with type 1 collagen. Type 4 forms the basis of cell basement membrane. Type 5 collagen and type 11 collagen are minor components of tissue and occurs fibrils with type 1 and type 2 collagen respectively. Type 5 forms cell surfaces, hair, and placenta.
Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at extract 1.
You hear a clinician called Jonathan Cross giving a presentation to a group of healthcare providers. You now have 90 seconds to read the questions. My name's Jonathan Cross, and I'm here today to discuss the somewhat controversial topic of unrestricted visiting hours throughout all departments of a hospital, including ICUs, our intensive care units. Across the globe, in every ICU, regardless of discipline or location, determining appropriate visiting hours is and will likely remain a challenge. Traditionally, physicians, nurses, and other clinical disciplines have behaved as though critical care units are designed for them rather than for patients and their loved ones. It now appears the tide is turning on the part of clinicians to provide enhanced benefits to patients and their families by making more time available for visits. This is seen by many as a positive change, but with any new initiative, there are those who oppose the shift in culture and cling steadfast to more conventional ways. So what are the problems associated with open visiting hours? Without question, liberal or unrestricted visiting hours can be more burdensome for clinicians who work in the ICU, particularly nurses, because of the potential disruption of daily workflow that might result from consistent family presence at the bedside. As most healthcare providers assert, to navigate the bedside of critically ill patients without family presence is less cumbersome. It's this that's prompting the naysayers to pose questions like, how will open hours affect the staff? Will it lead to adverse effects on patients or staff? The real question, however, is why open visiting hours causes such concern among critical care personnel. Multiple studies have been done and have repeatedly reported no adverse effects, such as infections or unstable vital signs, or on quality of care, and yet clinicians continue to cite concerns about safety as justification for restricted visiting hours. There was a recent study published in Intensive Care Medicine by Gianni and colleagues who identified the level of burnout among physicians and nurses in 8 Italian ICUs prior to and at 6 and 12 months after liberalizing visiting hours. This study demonstrated 2 important findings. Firstly, there was a 10% increase in the reported level of burnout at both time periods after visiting hours were opened. This increase was seen predominantly among the nurses. Secondly, despite the increase in the reported levels of burnout, the opinion of the physicians and nurses toward having unrestricted visiting hours remained favorable and essentially unchanged before and after the policy change. This latter finding is an important one and represents a significant shift in attitude. Both physicians and nurses acknowledge the importance of open visiting hours to patients and their families. This suggests that even at the risk of their own discomfort, providing enhanced benefits by way of additional family time for patients is a priority for clinicians. An important issue that was not covered in the trial is the potential of family burnout. A prolonged presence at the bedside may expose family members to another type of anxiety caused by frequent interruption due to healthcare professionals who may not always prioritize communication with families, especially when unexpected deterioration of the patient occurs and rapid life-saving measures have to be taken. Therefore, opening of visiting policies should be accompanied by the implementation of a consistent family support policy, including social work, palliative care, and other counselling services to improve communication with families. While some supposed benefits of open visiting hours are clearly beneficial, such as allowing for families with difficult work schedules to still visit or enhancing shared decision-making about patient care, there are also those that seem to stretch the realm of possibility. One such controversial benefit is facilitating family presence for CPR and procedures, areas traditionally off-limits to family and friends. At such a time as CPR, for instance, it's suggested that witnessing this will in some way improve family outcomes and provide closure. Surely the level of stress during such a time on the parts of both staff and witnesses would be too much, and it's during such times that families should be requested to leave. I'd like to state here that open visiting hours does not mean visiting without rules. Family member behavior can be restricted if it is disruptive to the care of the patient or other patients in the ICU, and family members can be expected to follow the same rules concerning infection control as ICU clinicians. These are the facts. Administration as well as families must be educated to understand the demand that open visiting hours presents. Clinicians must also continue to be supported. By doing so, we may just usher in a new era in which patient-centered, family-centered, and clinician-centered care can all be one and the same. As clinicians who are loyal to the interests of our patients, we owe it to them to provide them the kind of environment in which critical care and death have occurred for many years outside the hospital, surrounded by the people they care about the most, rather than by strangers. You hear a clinical dietitian called Rebecca Hudson giving a presentation to a group of healthcare providers. You now have 90 seconds to read the questions.
My name's Rebecca Hudson, and I'm a clinical dietitian working here in the hospital. Today I'll be presenting what some consider a very challenging topic, raising the issue of weight loss and obesity with patients. A person's weight is a complex and sensitive issue. Many factors are at play, like concerns about being judged, feelings of embarrassment, or even failure. As a dietitian, I see this on a daily basis. Yet beginning discussions about weight can still be unsettling for both myself and the patient, who often knows it's coming. This is because, as healthcare providers, we're sometimes uncertain of how to discuss weight-related issues while still providing support to our patients in ways that are empowering and non-judgmental. During the consultation, we strive to get our message across, but if we lack the initial training to do so, chances are we'll lose trust and irrevocably damage the provider-patient relationship that's so vital. We risk stigmatizing or even shaming our patients to the detriment of treatment goals and inevitably patient outcomes. So how is effective communication achieved for sensitive matters? Often a healthcare provider's comments as they open the channels of dialogue with the patient are the most important. A patient's level of comfort in discussing their weight needs to be established. Asking directly if they're okay talking about their general health and weight is the most efficient way to do this. Once the conversation is moving, I've personally found that tactfully choosing terms like excess body weight or above ideal body weight far easier on the ear than excess fat or obese. This practice is very important in establishing trust. One method I've found very useful during this time is not referring to them as the condition. It's common these days to hear that a patient has diabetes rather than is diabetic. This crosses over to has obesity rather than is obese. The next step in maintaining dialogue with the patient is by way of open-ended questions and ensuring we articulate them the way they're intended. This is achieved by first eradicating all implicit assumptions and bias about obesity to ensure that we don't give patients a feeling of being judged. Let me give you an example. The basic questions used by dietitians are based upon 3 of the main factors that influence a person's weight: their eating, drinking, and exercise patterns, as well as their previous attempts at weight loss. If I say, I think you need to lose weight, this is my opinion, a judgment. Now, consider an alternative like, are you interested in losing some weight? This suggests that you're likely sympathetic to any past attempts, that you're willing to provide them with support across the board, and it allows the patient to begin the conversation without feeling judged or criticized. There are, of course, occasions when consultations don't go as planned, even after your support has been well established. I'm a strong believer, as are many of my colleagues, in relating a patient's weight to their current medical condition, whether it's diabetes, heart disease, osteoarthritis of the knee, or disease of the eye. Regardless of the condition, the general health of the patient is paramount. This is a technique that, when employed with tact, will prove a very persuasive one, as often obesity is considered a separate issue. So, when it's seen as a contributing factor, and therefore one that, if brought under control, may reduce symptoms such as chronic pain, the effort needed to make the change soon appears less significant. Education and ongoing support for the patient will reinforce a healthcare provider's advice and recommendations. This can be as simple as providing patient fact sheets and brochures about their current condition, as well as the benefits of weight management. My personal recommendation is to carefully select 2 or 3 measurable, achievable goals and discuss the steps necessary to reach them. This is also a valuable time for the healthcare provider to evaluate the patient's readiness to make the necessary lifestyle changes to lose weight, as well as the extent of familial support, the latter often being a key element of success. All that I've mentioned here today are examples of what dietitians refer to as motivational interviewing. This is an open-ended way of interacting, built around helping patients go from being disinterested in or against a behavior change to taking steps toward being willing to make some changes. It is an open-ended approach to trying to learn where the patient is coming from and what they want, and helping them lead the way towards positive behavioral changes. It starts with trying to get the patient to open up about their feelings, rather than assuming we know who they are, and then together coming up with a set of initial steps they can take. We need to engage the patient, and then the patient activates the behavior change.